So hello everyone, my name is Nina. We're going to be doing a discussion on management of thoracic patients who are critically ill. The brief that I was was to discuss patients that were coming in for a thoracic surgery that were critically ill, and to sort of take you through what the pre-op, intra-op, and the post-operative bits were. So the way I've kind of played it around is that I've taken real life scenarios, and we'll do an interactive discussion. We'll sort of discuss what the presenting problem was, what the pathophysiology was, what the intraoperative course was, and what the postoperative challenges were, and where these patients needed sort of multi-organ support or where critical care was. Can you all see my slides?
Yes.
Okay, lovely. Right, so before we start, because this is an interactive sort of discussion, I just want to test it. Can you see this question on your screen with a scanner, a QR code on the top left and a web browser link on the right? And if you can see it, you try either scanning the code. It should take you directly to this question and allow you to make a choice. Alternatively, you can try typing poll.ev.com/Minarana640. That should also take you to the question. We'll give it a minute or so for everyone to try. Is it working? Seems to be working, yeah?
Yeah, tabs.
Okay. Okay. I think we've had some responses. I'm assuming it's working. Okay, it is working. We've had some responses. Is it easy for everyone to follow? Is it working for everybody? If you could just by some means let me know, because I think we've got some answers.
It worked fine for me.
Okay, fine. So the first scenario is this patient who's 19 years old. He was added to an elective thoracic list for a VATS washout and a drainage of an empyema. The history was a 3-week-long history of cough and pyrexia with chest pain. He was actually transferred overnight across to our hospital from the district hospital with a left-sided chest drain in situ. The other history that we had from him was travel to Greece, Prague, and Scotland. There was a history of open water swimming. His whole family had DNV, and he sort of got worse whilst everyone else recovered. There was no other significant past history. He had no comorbidities. He never had any surgery or anesthetics in the past. His blood test just showed a massively elevated WBC count with a CRP of 400. Everything else was pretty much okay. There was no significant microbiology that we had at the time of him presenting to our hospital. He had 48 hours worth of tablets and clary. This is his chest X-ray. And this was the chest X-ray that was taken prior to the chest drain going in. You can see that there's a big cavity on the left-hand side with a significant air fluid level, which is pretty much compressing most of the lung. And this is a CT scan of the same patient prior to the chest drain going in. You can see there's multiple cavities. There's one anterior, there's one in the posterior paravertebral region that has a clear air fluid level. And it sort of extends all the way lower down. This is just below the level of the division of the trachea into its two main, right and left side. Okay, so this patient was brought into theaters with his left-sided chest drain in situ. There was a thick yellow pus that was draining out from the chest drain. Within theaters, he was tachycardic. Heart rate was about 120, 130 with sinus. Blood pressure on an IBP was 110/60. His GCS was 15/15. He was quite pyrexic. Temperature is about 39.5. Still brisk refill of the capillary. We managed to sort of get a 16-gauge cannula in him and start fluid resuscitation. Gave him about 1 liter of fluid in theaters before we started the induction. So at this point in time and with this history, if you could rank sort of in order of what you're most concerned about, the least. Give it 10 more seconds and then. Okay, that's interesting. So most people are concerned about hypoxia at induction followed by hemodynamic instability. Contamination of the better lung comes third. Infection risk during airway manipulation, and then obviously, hemodynamic instability. We'll just wait. We'll just wait for a little bit more.
I'm still thinking.
Okay. So I think it's hypoxia that's winning. Hypoxia at induction, and then hemodynamic instability, and then post-operative care and communication sort of is coming quite lower down on everyone's priority. Right. What was I thinking? I was actually concerned more about hemodynamic instability and sepsis. That was my number one sort of concern because the patient in front of me, I could see that he was compensating quite hard at 19 years of age. You know how they can compensate to quite an extent before they crash and burn. I was also worried about post-operative destination, where the patient would go, because this patient was not booked for ICU. He'd just been transferred overnight across. Nobody in the ICU knew about this patient. And to be honest, nobody had seen the chest x-rays and the CT scan pre-op. It was only in theaters that they saw it for the first time. Was also worried about infection risk because we did not have any microbiology. We'd not sent off any tests for this patient at all. And with his history of travel, I was very concerned about what weird and wonderful bugs they might be growing. I was then worried about hypoxia. And I was, to be honest, the last thing on my list was contamination of the better lung. So what happened post-op? So we gave this patient a good more than 8 minutes of pre-oxygenation time. Whilst we were resuscitating him with the fluid and getting the lines in, we immediately put the oxygen mask on him. We sort of gave him 100% oxygen. We started phenylephrine at 5 mils and we did a TIVA induction. The blood pressure was actually a bit labile, but not too bad given everything. His MAP was always above 65. The heart rate began to settle a little bit post the liter of fluid. We put a left-sided DLD to intubate the trachea. And during confirmation of the position of the DLD, we found that it had actually gone to the right side. We managed to reposition it successfully. And this was a very controlled situation. At no point did we lose control of oxygenation. We knew the tube was in the trachea. We knew we could ventilate the lungs. And the timing between the discovery that it had gone onto the right side and repositioning wasn't actually too long. It was just a couple of seconds, really. But during this time, the patient desaturated very, very rapidly to about 55%. So this is an open-ended sort of question. You should be able to type in freely once you click into it. And then we'll have a discussion based on what the responses are. Why do you think this patient desaturated so rapidly?
I tried scanning you, I can't, but my camera's too bright.
You need a scan or on your web browser if you like.
It's an email, I probably scratching over there. Or nothing. Less than air.
Found a hypoxic mixture somewhere.
Just a sealed mask with no gas coming in.
Yes. Oh, why are they desaturated?
Interesting. Yeah. I'm sorry. Go back to the question. Okay, so I think a lot of the answers are sort of pointing towards VQ mismatch that often happens. There's also suggestion of high metabolic rate and high cardiac output, which combined with the VQ mismatch was obviously not helping. And then the fact that the DLT had gone in the wrong position, we had to change it, kind of made things worse. So there's increased oxygen requirement. As everyone is already thinking on those lines. He's a young fit male, probably his baseline metabolic rate is probably high to start with. He is septic. His temperatures were very high, 39, when he came into the theater. So he's obviously hypermetabolic. He was functionally on one lung. Most of the lung, as we saw from the CT scan, was compressed by the large abscesses. So he's just living on one lung. He's functionally on one lung. And despite the fact that we tried to pre-oxygenate him for a very long time, it wasn't enough. And this was one lung in supine position. So as soon as we induce the general anesthetic, there's an immediate setting of a VQ mismatch, which is in one lung ventilation. Supine position is the worst position to have for a VQ mismatch because both the lungs have an almost equal amount of perfusion. The gravitational effect that you get or the gravitational advantage that you get of one lung in lateral position is missing. So that kind of really, really exacerbates the hypoxia, and it is seen most often in people who don't have any lung disease because they're not used to it at all. So a little question before we go on to the pathophysiology of one lung ventilation. You have to choose the correct statement from the following.
Drop me a diagram.
You're talking about ventilation here from the left lung, isn't it?
Yes. So this is the left lung is non-dependent. After the right lung is getting ventilated.
Just need to have a little cry.
So this is, imagine the patient in lateral position with the left lung being non-dependent, the right lung getting ventilated and is dependent. So in that scenario, which of the following is correct? Okay, shall we move on? Okay. So we'll just go through the pathophysiology and then this is an excellent article if anybody wants to read. It's just come out in the month of July this year about hypoxemia during one lung ventilation. It describes very nicely the pathophysiology of one lung ventilation. Essentially what happens is there are three sort of conditions. You've got a supine patient and then you've got a patient in its lateral position with the right lung being dependent and the left lung being non-dependent. And in lateral position, you can have two further scenarios. One is where the chest is closed and not opened, and the other is where the chest is open. So if we just focus on the supine position first, when the patient is under the general anesthetic, both the lungs are getting an almost equal amount of blood. So the perfusion is almost equal. The right lung just being larger by its size gets about 55%, the left lung gets about 45%. So in this situation, when the blood flow is almost equal, the contribution of shunt is also almost equal because both sides at the moment are getting an almost equal amount of ventilation as well. So 2.5% as you would normally get, which is from your bronchial arteries that are not getting oxygenated anyways. It's equal. Now when the patient is turned, you get the effect of gravity. So the perfusion now preferentially goes to the right lung, which is your functional lung, and therefore it gives you a slight advantage. And the blood flow is now about 60 to 40%. And the shunt consequently drops to about 1% from the left lung, purely because now the perfusion is slightly less. And the right lung is now contributing to about 4%. Also, additionally, there are some changes that are happening with the compliance. So on the compliance curve, in an awake patient, okay, let's do that later. Let's just finish the right lateral. Once the chest is opened, the atmospheric pressure immediately compresses the left lung or the top cavity a lot, and it pushes the mediastinum downwards, which then compresses on your dependent lung. So whilst it pushes the blood or squeezes the blood out from the left lung to the right lung and increases the blood flow to the left lung to the right lung, it also causes compression or atelectasis, and therefore that worsens the shunt a little bit. So from 4%, it goes up to 5%. But at this point, the left lung is getting about 25% blood flow. All of that is shunt because now there's no ventilation going in. So the worst position to be in is open chest, lateral. Yeah, does that make sense? Okay. The other thing that we need to understand is what happens to the compliance. So on the compliance curve, the best thing is when a patient is in lateral decubitus position, is awake or not paralyzed. In that position, the diaphragmatic movements would allow maximum movement of the dependent parts of the lung, where it would then preferentially draw the ventilation. So your VQ mismatch would naturally be optimal. When you paralyze the patient, you're pushing, the diaphragm is pushed up with the abdominal contents, and then you're doing positive pressure ventilation. So you've done everything opposite of what is good. And therefore the VQ mismatch gets worse. So just some of the things about one lung that are interesting and you have to kind of move about and play about when you are dealing with hypoxia under one lung ventilation. You're dealing with compliance, you're dealing with shunt. So you have to kind of make sure the blood pressure is optimum, try and recruit the dependent lung as much as you can until hypoxic sort of vasoconstriction sets in, which then helps you. Any questions? Everyone happy? Okay. So what happened intraoperatively? We isolated the lung and we sort of positioned the patient with his left lung on the top, and we immediately noticed copious amounts of yellow serous fluid coming out of the bronchial lumen of the DLT, which was situated in the diseased portion of the lung. The surgeons put in their camera and the port, and they found a lot of effusion which was washed out. They found an abscess cavity as well on the posterior side, and they drained about 500 mils of foul smelling pus. And at this point, the patient begins to get hemodynamically more unstable, and we swapped the phenylephrine to noradrenaline because the phenylephrine was a ridiculous amount. The PF ratio was about 200 in that position. The PaCO2 began to climb to about 7, and we still got persistent pus coming up the bronchiole. We were just suctioning and suctioning and suctioning. It was still coming up. And this wasn't happening before. So with this, what do you think has happened? What is your diagnosis? It's an open-ended, freehand type, whatever answers you think.
Can you please repeat the question again? Besides, what is your diagnosis?
Yes, so if I'll just take you back to the slide. So this is the situation. Once the patient was in lateral position, we noticed a lot of serous fluid coming up the bronchial side of the DLT. And the surgeons were able to sort of drain the abscess cavity and the effusion, but despite that, there was persistent pus that was coming up the bronchiole. So based on this history, what is your diagnosis?
Bronchitis bulbous.
Okay, so I think everybody says it's bronchopleural fistula. It is a bronchopleural fistula. Where were we getting any nuances? Positioning related. Okay, bronchopleural fistula. Yeah. So it sounds like a bronchopleural fistula, which is actually quite commonly seen in these patients who have. He had a 3-week history. There was a big abscess. It had air fluid level in it. So there's a very high chance that it had eroded into one of the airways. And when we positioned the patient, combined with the disturbance from the surgical side, when they kind of pushed the cavity, it must have just opened up. And that is why we were getting copious amounts of secretions on the bronchial side of the DLT. So at the end of the surgery, when we turned the patient supine, the PF ratio deteriorated by about 50%. So it went down from 200 to 100. And he was now hypercarbic and respiratory acidosis. His vasopressor support was at 0.7 mics per kg per minute. He'd had about 30 mils per kg of fluid resuscitation. He had 2 chest drains on the left side. They were bubbling aggressively. And we were also struggling to ventilate him. I think our flows were about 10 liters. And with that, we were just about managing to get about 300 mils of tidal volume through him. And at this point, given the fact that we knew that there is a bronchopleural fistula, we had a discussion with the ICU as to whether we should leave a DLT in situ, because that would help with the toilet of the lungs, and also it would keep the healthy lung safe, given the fact that he was completely dependent on the healthy lung. And we ultimately decided not to put the DLT in because obviously management of a DLT is a skilled, so it needs skill around, and it can be more dangerous to leave it in if we don't have the skill and sort of to deal with the malpositioning and handling, etc. for it. So we ended up changing the DLT. We left the DLT in, we suction and suction and suction. We did a lot of lavage. We did a bronchoscopy at the end. And when we were happy that most of the stuff had either come out of the chest drain or had been coughed up, we changed it for a single lumen tube. It's not ideal because there's still a risk that it might get, the healthy side might get soiled, but in the given circumstances, it was the best thing we could do. So bronchopleural fistulas, they have a variable incidence. Quoted literature is between 4 to 20%. Most commonly, we see them in a chronic setting post-surgery for a pneumonectomy or a lobectomy. And they're more commonly seen after a pneumonectomy if the bronchial stump hasn't healed properly, or there's been an infection in the immediate postoperative period. You can also see it in an acute setting following a trauma, blunt or penetrating, and you can see it with in the setting of empyema, pneumonia, or infections, although very less commonly so. And the main challenges that you would obviously see are risk of contaminating the sound lung or the same part of the lung if it has a healthy lobe remaining. You obviously struggle with ventilation because there's loss of gases through the fistula to the pleural cavity. And if there is no chest drain, then you can have a tension pneumothorax as well. So if there isn't a chest drain and you're suspecting a bronchopleural fistula, isolate the lung as soon as you have DLT. Do not give them positive pressure ventilation. Just treat them like rapid sequence intubation, put the DLT, isolate, and then start positive pressure ventilation. The management of these patients once you have them on positive pressure ventilation, you would want to obviously reduce the peak inspiratory pressures in the peak, and you would want to limit the negative intrapleural pressures. You want to isolate the lung as soon as possible and ventilate the lung that is healthy and doesn't have the fistula in it. In severe cases, you do need to have the patient on ECMO till such time you can sort the immediate period off. And then the definitive management involves either bronchoscopic placement of valves or fibrin or glue and other such occlusion devices, or in extreme cases, you may need to do a plastic surgery with the reconstruction of a muscle flap in order to seal the area. And actually, for those of you who are on Glenfield, we have a patient on the unit who has had a reconstruction only yesterday for a bronchopleural fistula post surgery that has been complicated. He's been in hospital for about 3 weeks. This is a photograph of the CT scan that shows the fistula, the communication between the cavity and the right upper lobe bronchus, and a bronchoscopic view of the same that was sealed with fibrin glue. And this is how they use a muscle flap. They essentially just raise, I think it's the serratus of the latissimus that they use, or maybe sometimes the pec, I don't know which muscle they use, but they lift a muscle off the chest wall and insert it inside the cavity, kind of glue the area or to obstruct the area that has the fistula in. Okay. This is an excellent article for those of you interested on how to manage bronchopleural fistulas in mechanically ventilated patients. It's actually quite recent. It's quite nicely talks about the physiology and the mechanics of a bronchopleural fistula. Very helpful. Okay, any questions on this scenario? Are we all happy? Yes.
Can you show a picture of the bronchopleural fistula again, please?
Pardon?
The bronchopleural fistula CT scan that you showed for this patient.
Yep. It's not for this patient, it's a different patient. I've just taken this.
I just thought it's this patient because it's on the right side and I thought it was the left side.
It's a different patient that I took a CT scan image from. Okay, so we move on to the second scenario now. This is a patient that I unfortunately had the pleasure of anesthetizing last year. She was a 57-year-old who presented with mild shortness of breath and some chest discomfort. And a large anterior mediastinal mass was found on her initial chest X-ray and CT scan. Her symptoms were very rapidly progressive, and she developed orthopnea, she developed substernal chest pain, and a worsening shortness of breath. When they did a repeat CT scan, they found that this mass had grown. It was compressing the right lung and was possibly extending into the SVC and the right atrial appendage. A biopsy showed that this mass was actually a thymoma. It's a very rare presentation at this stage of a rapidly progressive thymoma. So because her symptoms were so rapidly increasing, she was referred to the hospital for urgent surgical workup. And during the inpatient anesthesia consult, we found that she had symptoms of myasthenia gravis, and this was not picked up before. She did not have any other comorbidities, thankfully. It was just this. And this is a CT scan. You can see there's this massive mass that is occupying most of the right side of the chest and is compressing on major bronchovascular structures. It's about 12 by 9 by 8 centimeters. It was causing compression of the right upper and middle lobe. This particular slice does not necessarily focus on that. I'm just telling you the summary of the CT results. The central tracheobronchial tree was widely patent. It was just a compression of the right side of the bronchovascular structures on the right side that were getting affected. but it was closely related to the superior vena cava and the right atrial appendage. It wasn't really invading it. It wasn't really commented in the CT scan whether it was invading it, but it was very closely related to these structures. So you have a patient with a large, rapidly growing thymoma with evidence of compression of the bronchovascular structures on the right side, with history that was suggestive of myasthenia gravis, but that wasn't formally diagnosed, and she has not been started on treatment for her symptoms. So again, open-ended question, what are your concerns based on this history? Okay. Interesting. People are actually engaging in this. Okay. I think the common theme is we are worried about myasthenia causing post-operative respiratory failure. We are worried about airway compromise. We are worried about cardiovascular compromise because this is a large mass that's compressing on bronchovascular structures. Okay. So preoperatively, you need to risk stratify. We needed to risk stratify this patient. We needed to risk stratify her from two aspects. One was obviously cardiovascular compression. And how much would that be intraoperatively when we induce general anesthetic with neuromuscular paralysis? And obviously the perioperative optimization of myasthenia gravis. So we took a very detailed history for this patient. We asked her about how severe the shortness of breath was, how quickly it was progressing, whether there was any feature of stridor, and whether we could sort of pinpoint to it being in the inspiratory, expiratory, or biphasic pattern. We all know that this kind of correlates with the compression being intrathoracic or extrathoracic or fixed. It's very, very important to ask about shortness of breath with posture, and in particular, whether the patient feels relieved of the shortness of breath in a given position. This is called as a rescue position, and this is very, very important because intraoperatively, when all else fails, it is the rescue position that will save you because that will just allow the mass to fall away from the structures that it's compressing upon. We also need to know the degree to which the patient can lie supine because that would be the position in which you would have to induce this patient. And any other signs of vascular compression, i.e. syncope, you can look at prominent veins in the neck, you can ask them for history of dizziness, fainting, etc., etc., etc. So what we did for this patient was we did a neurology referral, and because this was a very aggressive thymoma, she ended up having 5 sessions of plasmapheresis pre-op, and she was started on steroids and pyrethostigmine. We also did an MRI because we were worried about it being very closely related to the SVC and the right atrium. And the MRI actually revealed this is a massive mass that was extending all the way from the diaphragm to the inferior cavoatrial junction. It was very closely associated with both the right atrium and the SVC, just below the level of the brachiocaptic vein, and possible invasion of the right atrial appendage. The echo, thankfully, was normal. Just a little bit about risk stratification scores. There's a very good article here that I've attached the link to, which kind of combines the various modalities that we have on the basis of which we risk stratify these patients based on postural, how symptomatic they are, and what the radiological evidence of compression is. And we divide them into low, intermediate, and high risk. So low risk are where the patients are either asymptomatic or mildly symptomatic with no postural symptoms, and there's no radiological evidence of compression. The intermediate risk are patients who've got mild to moderate symptoms with postural involvement and a tracheal compression that's less than 50% of its diameter. The high-risk patients are those who have stridor or are cyanotic with severe postural symptoms and a tracheal compression on radiology that is more than 50% of its diameter or associated with bronchial compression, and there's evidence of pericardial effusion or SVC syndrome. It's actually quite nice because I think this is the first paper which put together everything for adults. We had a system for pediatrics. We did not have it for adults. So this kind of puts it together. Intraoperatively, we identified this patient to be at an intermediate risk for adverse cardiovascular events. And we had a multidisciplinary team meeting, which involved the oncologist, the surgeon, the neurologist, the intensivist, and the anaesthetist. This patient was managed at a center that had ECMO facilities, and we decided to do a preoperative awake fiber optic bronchoscopy under topical anesthesia. And this is actually quite a new modality. You can assess the airway compression in a dynamic manner. So you can see how bad it gets during expiration, how bad it gets during inspiration, and you can plan your airway accordingly. So if it's really bad at any phase of the breathing, you know you would have to do an awake fiber optic. There is no way that you would go with a GA. And this is again a new sort of thing that has come in the last year or so. And on this fiber optic bronchoscopy, we found that there was no obvious central tracheal compression, but the right-sided segmental bronchus was quite severely compressed. And it was fixed compression, both in inspiration and expiration. So we discussed with the ECMO team if preemptive awake cannulation of the femoral vessels was needed because we were anticipating possible intra-SVC compression. And it was ultimately decided that we would have a perfusionist and an ECMO circuit ready on standby with a member of the ECMO team scrubbed in anticipation of an emergency cannulation, but we did not preemptively wire the femoral vessels. Everyone in the team was made aware of what the rescue position was, and that was right lateral in case of an emergency cardiovascular compressive event. The surgical team was also ready with a rigid bronchoscope if needed if we completely lost the airway. We decided that we were going to secure the airway after general anesthetic, and the induction of a general anesthetic in these cases where you've got a massive mediastinal mass is based on the principle of this. It's a Latin term. I can't speak Latin, so I'm just going to give you the English translation of it, which means don't burn your bridges. So you move in a stepwise manner. And what that essentially means is that you start off with inhalational induction using sevoflurane, and you slowly increase the depth of anesthetic. It's difficult in adults because they don't really like awake inhalational induction, but you've got to have a chat with them pre-op. And as the depth of the anesthetic is slowly increased, you see if you can take over a part of the patient's ventilatory effort through positive pressure ventilation. If you are able to do that and you're able to successfully establish bag mask ventilation without any signs of airway compromise, then we started with a little bit of IV ketamine and a little bit of IV propofol to deepen the anesthetic. Performed the laryngoscopy, and we were able to intubate the trachea using a DLT. Once positive pressure ventilation was established post-intubation, only then did we give the neuromuscular agent. So this is essentially stepwise manner. Don't burn your bridges, i.e. start with inhalational. Make sure you can do positive pressure ventilation. You can bag mask the patient. Once you can bag mask the patient, then you give them a little bit of IV agent to deepen the anesthetic. Then you intubate. And once you are sure that the tube is beyond the most compressive part of the airway, then you give the muscle relaxant.
As you managed to tolerate the CMAC using the ketamine and propofol?
We did, yeah. We were able to. All was well until now. And then midway they did a clamshell. The plan was to do a clamshell thoracotomy because it was a massive mass. They opened the chest and they were starting with the surgery, and then suddenly the patient became hypotensive and hypoxic, and it was refractory. We called for help. A TOE was done. And we found that the RV was with dilatation and evidence of raised pressures on the pulmonary side. The patient is immediately put on BV ECMO and then BVA ECMO. The mass was rapidly resected and the patient was transferred to ICU. So what had actually happened in this case was that as soon as they opened the chest, due to the mass effect of the tumor and the effect of the general anesthetic, it completely collapsed on the right side of the lung, leading to loss of airway and intraoperative hypoxia. There was also additionally obstruction of the SVC and the right atrium, which decreased the preload. There was profound refractory hypotension. And because of the drop in the preload combined with the ventilatory insufficiency, there was a sudden rise in PA pressures and a functional or a dynamic RVOT tract obstruction, which is why the patient had to immediately go on to BVA. Post-operatively, she was fine. We were able to wean her off within 24 to 48 hours because the mass effect had gone and she didn't have any residual sort of impact on the right side of the heart. She was weaned off ECMO, she was extubated, she was sent back to the ward and she was fine. But this was a very interesting case. Okay, and that would be the end of my presentation. If you have any questions, please feel free to ask.
You have a standby cardiac surgeons just in case if the mass was attached to the right atrium.
Yeah, we have the whole thing ready.
Yeah, couple signs of post-operative complications like myasthenia or accumulation.
I followed her up actually, and once the mass was out, the antibodies just washed out from the system. She was fine. She didn't need any other. She was weaned off the steroids. She was weaned off the diuretic. It was all related. It was a very rare thymoma that was causing that.
What's the NPIC protocol?
What? Sorry. Could you please repeat?
You mentioned the NPIC, don't burn your bridges. What's that about?
Oh, that is, it's not a protocol. It's a term that was coined by one of the thoracic anaesthetists, which stands for don't burn your bridges. So that's essentially induction of anesthesia in a very stepwise manner. So you slowly increase the depth of the anesthetic, starting with an inhalational anesthetic, and then see if you can bag mask the patient. And if you can bag mask the patient, then you can deepen the anesthetic using IV agent, then intubate. And once you have intubated, then you make sure that you can still ventilate, because sometimes the tube is just proximal to the point of maximal obstruction. So your tube may be in, but you still might not be able to ventilate the patient. So once you've intubated and your tube is in and you secure the tube and you can positive pressure, you can ventilate the patient, then you give them the neuromuscular blockade.
I see, thank you. And sort of, is there reasoning as to why you use a mix of ketamine and propofol?
It was personal preference. You could use anything as long as you're able to deepen the aging. I think ketamine kind of preserves your airway reflexes theoretically, or whatever it's worth. I think you're just trying to reduce and be very careful and be as titrated as possible. You could use anything. There's 1,000 ways to skin a cat.
And can you say what is the reason behind why not awake fibrotic gestation?
We did a preoperative awake fiberoptic bronchoscopy on this patient. We found that the central airway was patent. It was only the right segmental that was blocked. So it would have been more comfortable for the patient to do it asleep rather than awake. But if we had found that there was significant compression dynamic on the fiber optic bronchoscopy pre-op, we did tell her that we were going to do an awake intubation for her.
Have you got any sort of tips for an awake fiber optic intubation when you're actually needing to get quite? Because basically a lot of the time when we do awake fiber optics, it's because there's something here or it not moving here. So actually kind of once you're into the trachea, you're usually fine.
Yes.
It seems to me a lot more stimulating to be actually down in the bronchus. Is there anything in particular you do?
We used to, so for these patients, we usually, so obviously you would anesthetize the airway topically quite nicely as much as you can, so give them a good time. The other thing that I find useful is before you actually go in with your fiber optic scope, you can try passing a very thin Giles tube or a suction catheter, a long suction catheter, and see how the patient is responding to it. So if it is properly anesthetized, and actually that gives them an idea of what to expect. Okay. So if they're tolerating that, it's anesthetized well, they're mentally prepared for it, and they might tolerate it a little bit better. Those are the only two things that we do that I think might help. The rest of it is really
move your body to verbal anesthetic, do a little bit of sedation if you can. Yeah, but a lot of topical anesthesia.
And is there a reason you haven't used training for this patient?
In this case, no, I think we were just following the boss there.
Good stuff.
Okay.
Cheers, Minal. That was really interesting.
Very interesting.
I'm Becky. I'm one of the anaesthetic trainees working at the Glenfield ITU at the minute. And I'm presenting today on this article, which was published last month in the BJA, and it's titled The Efficacy and Adverse Events Profile of Videolaryngoscopy in Critically Ill Patients, a sub-analysis of the INTUBE study. On the first page, just below the abstract, in the sort of editor's key points box, is this statement, which is pretty bold. So these findings support systematic adoption of videolaryngoscopy in critical care. So let's look if they do. So essentially, this article is written based on the INTUBE study, which was actually performed back in 2018-2019. And it was a prospective cohort study, which enrolled critical care patients from 197 centres in 29 different countries across the world. And the aim of that study was to assess the incidence of peri-intubation adverse events, with a secondary aim to evaluate the real-life airway management in critically ill patients. So there were a lot of patients who were included, so almost 3,000, and each centre was given an 8-week period within that time frame to record the data for anyone needing intubation for a life-threatening condition within hospital. It didn't exclude anyone who needed intubation for a sort of emergency general anaesthetic. It excluded patients during or immediately after a cardiac arrest, and also anyone that was intubated sort of out of hospital and then brought into hospital. There were around 500 patients excluded, and that was generally due to lack of information being recorded. So this article sort of looked back at that data that had been recorded. Obviously, that during that study they recorded loads and loads of information. So this article was sort of to further look into that data that had already been collected. And the primary aim was to identify an association of videolaryngoscopy use with first pass intubation success. They appreciate that there are lots of things, because that wasn't an RCT, it was just what did you use when you intubated the critical care patients. There were a lot of co-founders that could sort of influence that. So they had some covariants that they considered, so the BMI of the patient, predictors of difficult airways, site of intubation, so whether that was in ED, on the medical wards, in ITU itself, the urgency of intubation, use of neuromuscular blockers, and operator experience. And then the secondary aim was to identify an association of videolaryngoscopy with major peri-intubation adverse events, because historically, there had been some concern about sort of adverse events whilst using videolaryngoscopy when compared to direct laryngoscopy. So they felt that was an important aim to address. And again, as we can appreciate, in these critical care patients, there are lots of things that put them at higher risk of having sort of adverse events during intubation. So they came up with these covariants, so age, SOFA score, the SATS to FiO2 ratio, the systolic blood pressure, use of vasopressors prior to intubation, operator experience, urgency of intubation, use of propofol as the induction agent, and first pass success. The adverse events that they were looking at were cardiovascular instability, severe hypoxemia, or cardiac arrest. When they talked about CV instability, they were sort of things that they identified as causing that were systolic blood pressure, well, defining that, were systolic blood pressure below 65 at any time. at any time, or less than 90 for a period of 30 minutes, or new or increased vasopressor use. And severe hypoxemia was defined as SATs less than 80% at any time. So this is sort of their sort of raw data results, so uncorrected for the covariants, and essentially showed that if you use a videolaryngoscope, you have a higher first pass success rate, and that was statistically significant. There was also reduced cardiac arrest, reduced esophageal intubation, and reduced cardiac arrhythmias in a statistically significant way. But it did also find that using the videolaryngoscope slightly increased the risk of cardiovascular instability. But as I say, this was on the raw data. They then used inverse probability weighting on the covariants, and again found that videolaryngoscopy had a higher first pass success rate, and they combined the adverse events together and used this inverse probability weighting, and found that collectively there was no significant increase in the incidence of peri-intubation adverse events. So I sort of used the CASP toolkit to just have a look at it with regards to how good a cohort study was this. And so I went through the sort of 3 groups of questions. So the first one assesses validity, and I felt that the questions were clearly focused. It was a representative cohort. Most of the outcomes were objective. There were a couple that I wasn't convinced would have been written down. So some of the difficult airway predictors in a critical care patient, I'm not convinced that they would all be, Mallampati and centimetres of mouth opening. I'm not certain they'd have been recorded. And so accurate recording of both the measures and also sort of the success may have been an issue. The assessors were blinded. They themselves weren't participating in the study. And I felt that they did identify a broad range of appropriate co-founders, and they were accounted for by using this inverse probability weighting. The results were presented with both an unadjusted and adjusted for covariance manner, and they were both consistent with each other, which I felt sort of strengthened the results. As I say, they both of them showed the first pass intubation success was better with videolaryngoscopy, even though the groups that had videolaryngoscopes used on them had a higher number of predicted difficult airways. And the adverse events were not statistically significantly different between the 2 groups. So one of the questions in the CASP is, do you think these are believable? And I do think these results are believable, and partly because I then looked into some of the other evidence around at the moment, and it's consistent with that. It then asks, will it help locally? And I felt that it would. So our ITUs are pretty representative of the cohort, and the only sort of different thing for particularly Glanfield, a lot of our emergency intubations in critically ill patients tend to be post-cardiac arrest, and those people were excluded in this study. But then I also considered that perhaps QMC wouldn't, because I know when I went there 2 years ago, and I don't know if this has changed, but they didn't really use videolaryngoscopes, and I remember being told when I arrived and was like, where's the McGrath? They said it was because they have a lot of trauma, and so a lot of airway soiling with sort of vomit and blood and so on. So they tend not to use so much the videolaryngoscopes, because as soon as the camera gets obscured by blood or vomit, then they can't see anything. So they tended to use air tracks, I think, but that may have changed since I was there. So we do have videolaryngoscopes readily available in both hospitals. So in theory, yes, this could be very helpful for us, and we could apply it. But there are some limitations that it's important to highlight. So there's obviously selection bias. So centres that have airway interest may have been the ones that chose to participate. And if you have if you're a centre that has a particular airway interest, then you're more likely to have different sort of equipment and skill sets. So that was acknowledged in the paper. As I mentioned before, it did exclude these post-cardiac arrest and pericardiac arrest patients, and particularly at Glenfield, that might be important for us. Although obviously also at the Royal. And as I mentioned previously as well, the accuracy of documentation of the number of attempts that somebody had, obviously with these critically ill patients and emergency intubation, you're usually not just potentially intubating them, but you're also putting in lines and the patient's unwell clearly. So there's a lot of documentation and things that you're having to do. So whether they'd have all filled in everything absolutely perfectly is questionable. And again, with the adverse events, I mentioned earlier what they classified as adverse events. Well, unless you've got an arterial line, can you definitely say for certain that your blood pressure never went below a systolic of 65? And it classifies the CVS stability as new or increased vasopressor use. Lots of patients need vasopressors after intubation, but then they're also being given sedatives which drop their blood pressure. So that's a bit tricky. And again, with the SATs below 80, if you've got a patient who their blood pressure has dropped on intubation and then you get a poor SATs trace, can you say for certain that the SATs never drop below 80? And again, is that always absolutely documented? And of course, there are many covariants during an emergency intubation. So the documentation is certainly a limitation, in my opinion. And it was a worldwide study, and it's very much said this is a global study, but more than 50% were from Europe, and I think there was only 1.1% of the data was collected from Africa. So you certainly wouldn't be able to apply this to Africa because most of the cohort wasn't from there. And also they had quite a high bougie and stilette use, so about 62%. And I don't know officially what it is in our trust at the moment, but I suspect it wouldn't be that high from what I've seen. So with regards to further work and where we take this forward and what we should be thinking having read this, so my original thought was obviously this is a cohort study, which isn't the highest grade of evidence. So perhaps we need to do an RCT, which then I looked into, and actually there's been one done last year in America, which also shows that videolaryngoscopy has a higher first pass success rate than direct laryngoscopy. And again, printed last month in the BJA, there's this editorial printed, which is quite good, and it supports the use of videolaryngoscopy. So it basically says we've got the evidence that it's better, so why aren't we doing it? And how can we start to implement it rather than sort of continue to debate whether it's good or not? But they do mention, so with regards to further work and how we can use this in our trusts, it's sort of widely recognised that videolaryngoscopy is a skill that needs deliberate training. And I don't know where these numbers particularly have come from, some study somewhere saying you need to do 75 intubations with a videolaryngoscope before you can expect to be achieving 90% first pass success. And so is our deliberate training good enough to make this applicable in ICU, particularly with our non-anaesthetists, ICU doctors and advanced nurses? Are they getting enough exposure to videolaryngoscopy in non-critical care patients and in normal airways? As I said, suspect not sort of at the moment. We also need to sort of work with the more traditional anaesthetists perhaps who have reservations about us losing skills with direct laryngoscopes, and so therefore sort of avoid using them all the time, which obviously means that then we don't get skilled in using them all the time, and then so we're trying to use them in the critical care patients. So I won't say any more about that, but that is definitely a bit of a stumbling block, I think. But having read this and having looked at some of the other articles, I think it is worth considering us getting videolaryngoscopes for the grab bags. Certainly they're not in the ones at the Glenfield. I don't know if they are in the ones at the Royal, but that might be something to consider moving forward. And they mention a lot about the hyperangulated blades on the videolaryngoscopes being used in the more complex airways. So if you can't get a good view with the sort of standard McGrath, then you could use a hyperangulated blade. I haven't seen one of those at the Glenfield. I don't know where they would live if they are there. But again, I suppose it's about us all getting a little bit more familiar with them and what we would do in a difficult situation. And then probably we do still need further studies into which videolaryngoscope is sort of the best, as well as whether we should always be using a bougie or stiletto, and in which cases we wouldn't. So their sort of quite stark tagline, do they support the systematic adoption of videolaryngoscopy in critical care? Having read this, I feel like, yes, they probably do. And that's it. I'm happy to answer any questions if anyone has any.
Thanks, Becky. Any questions from anyone?
Got a comment. QMC has moved into the 21st century. Don't panic. There are now blind scopes everywhere. On the ITU, there's one in A&E, they're everywhere. There's now too many glide scopes. The other thing I would just say about hyperangulated blades is being a bit cognizant of where you put them, because you've got a risk with, if you just put hyperangulated blades kind of in the same place as your other videolaryngoscope blades, you have got a risk in the middle of the night of like somebody not realizing they're using a hyperangulated blade, which actually is quite a different intubation technique. So if we are instating hyperangulated blades on ITU, just making sure they're kept in a separate place. That's all I.
So are they on our ITU? Are they in the Glenfield ITU?
I don't know whether they're in the Glenfield ITUs. Have you seen one on our? No, not here.
That's a way of preventing this.
Yeah, excellent. Yeah, it's one way of preventing any problems. It's just don't provide.
I was just going to say, with regards to stilettos and things, there was a trial a couple of years ago called Stiletto or something, which was looking at whether or not you should use a stiletto for intubation in ITU, and that suggested that there's a higher first pass success rate when using introducer. And I don't know about anyone else, but especially if I've got a hyperangulated blade, I like a stiletto.
Yeah, I've definitely moved towards using a bougie pretty much every time I use a videolaryngoscope on the critical care patient. Finding a stiletto and making sure I've got a nurse or dart person who knows how to use them is slightly more tricky in an emergency, so I find a bougie safer.